Northampton General have recently become a teaching hospital, and what we're trying to do is become information-led. So what we're doing is this is the NHS long-term plan. So we're trying to work with the NHS to become more digital. It's a big challenge. We are very paper-based at the moment. The big part for the long-term plan is the fact that what we're trying to do is become patient-centric, put the right investment in local partnerships, reduce emergency pressure because there are more people coming into hospital, improve out-of-hospital care, but the digital enablement, which is my bag, which is where I come in, is trying to create a county-wide share care record and digitize the hospital. To do that, this is where my strategic move forward is to stop the paper coming into the hospital. So we're doing things like clinical noting solutions, which is where we use Alfresco, and the back office automation, again, where we use Alfresco. Get rid of the paper, so we're scanning. To give you a scale of the problem we have with scanning, I've got 15 people scanning at the moment full-time. If they continue, it'll take me 22 years to scan all the paperwork that we've got for patient records. So we have to rethink how we're going to do that. Make the data available, so it's around data security, data warehouse development, and sharing the data. And then share the informations, because if we're going to become an information-led hospital, I need all the information here in the data warehouse to then be shared out correctly. So the way I tend to look at this and describe this is from some of the vision moving forward. What would be the perfect hospital? So the perfect hospital would essentially have doctors, nurses, catering, cleaning, and everything else goes in the background. Wouldn't necessarily need to be there because things get delivered on time because you know what's happening. Where the patient comes in, depending on where they are, whether it's a doctor, an ancillary worker, or wherever they are, the information follows them. That then goes to the cloud. That would then enable a virtual case management tool, which means that the patient can then feed information back into the system. They can then book appointments, get reminders, monitoring themselves, preempt tests. All of that can happen. That's what we're aiming for. That's our utopia of where we're trying to look from a patient's perspective. And that would feel like a one NHS feel. But then when you think from a clinical perspective, that's slightly different because each specialty has got its own requirements of what it needs. So that you want the consultants to be looking at their view of the patient. And then you've got an ancillary would be looking more of a public healthcare focus and the view of the hospital. At the same point, again, feeding the back office and understanding from the patient perspective, so you've got this one NHS feel. So when we have data, the way I look at data is data has four real main use cases. So we've got the clinical decisions, so you want all the information in the right place. We've got the delivery of information management, so what we can do is know what, planning, what's going forward. You want the governance arrangements so that you keep people honest. And then I also want the information there for the person so that the data subject can get their access to their own data. And you can start having people helping themselves and looking after themselves a bit better. That bit is still yet to come. The patient portal is something we're moving towards, but that's definitely one of the use cases. Again, all wrapped up with GDPR and the security that comes with that. So when we're doing, essentially what we're trying to do is get people to do the right thing at the right time. So typically we'd have lots of training. Problem is what you want to do is have things that help them do the right thing and nudge them. So we talk about this intervention effectiveness, and what I'm trying to do is get to nudge theory and force functions so we can understand what they're doing and help them get it right. So in a summary for my strategic way of moving forward, and the reason we ended up buying Alfresco is because it gives me that flexibility and that platform to look after the data, create more data, and then manage that data. So what we're doing is we're stopping the paper. So we've got clinical noting solution that we're building in Alfresco. We've got the back office automation. Then I'm going to get rid of the paper. So then we scan. We've got some tools to scan the data, the bits that we need. Then we're going to kind of understand that data, the structured data, and actually enable that to be leveraged around the organization and other organizations. And then sharing that information across the Northampton Care Partnership as well as nationally. So that's the big agenda that we've got from a CIO's perspective. So these are the tools that we've decided that we want to do from a back office perspective, which is using the Alfresco tool. So ESR to AD, ESR is an electronic staff record. So that then feeds my Active Directory, then I can then ensure that when people leave and join, we can manage those people correctly. RBAC, role-based access control. Declaration of interest is a big issue because you've got doctors getting gifts all the time. They need to be able to share what those gifts are and what those interests are in case there's any conflict. An action tracker, because people are given actions all the time, and we've got actions from many different committees. Trying to manage those and make sure people deliver on them means that one view makes it easier. The org chart, a library of job descriptions, person specifications, a library of standard operating procedures so that people can know where to go to do the right thing. FOI tracker, freedom of information tracker. Objectives library, appraisals, one-to-one systems, letters timeline, so all the letters which are happening for the staff are in a timeline, categorized and easy to view. Notice of change is around changes to staff's pay, positions, because within the healthcare market, people tend to ricochet within the business. They move from one bit to another. We have our own kind of mini economy, and trying to keep track of things and where people are moving to is crucial to be able to deliver the right service at the right time to the right people. Leavers process and make sure that we don't overpay salaries. That's a big problem for most trusts. They don't get the information through. You've got an organization with 6,000 people. They're leaving all the time. Does the information go through to the payroll department? We need to automate that process. Contracts library, and then the EPM tool. So the EPM is the emergency tool, which is a tool I want to actually talk to you about, which is the elective pathway management. So elective pathway management is about the 18-week RTT target. And I'll give you a little bit of lesson on what this is. So when you come to the hospital, you've got a condition or something wrong with your hand or something, and it isn't an emergency admission. This is an elective admission. So what happens if you follow the pathway of what should normally happen, you see your doctor, he makes a referral. That referral then means you go and see a consultant. You might have some imaging, some tests done, some pathology imaging. You then go and see the consultant again. You'll have a treatment phase, and then afterwards there's a follow-up for outpatients. Now, there's a very specific rules that go with this. Very, very specific rules. And this is the 18-week RTT target that people hear about. The concept being it's 6 weeks to see the doctor, 6 weeks to get the test done, 6 weeks to get the treatment. That's the perfect treatment. But you've got many different specialties and there's many different problems. And this is causing a problem for the whole trust because we've got to get our performance right. So to show some of the complexity of that, time to see the consultant, time to see the diagnostic, time to see the treatment. The patient can come in. They could be provided to another hospital. There could be a thing called a watchful wait. If the people don't arrive and there's a DNA, then they have to start all over again. If there's a clinical need for the patient to be seen, so if it's a child or if it's a patient that is, then not turning up doesn't stop the clock. So all of these things help us manage the patient through this process because we don't want 52-week breaches because that is a massive fine to the trust and it's also publicly not a good thing to kind of admit to, which we have to admit to on paper, but we don't want to get to that 52-week breach. We don't want someone to be forgotten whilst they're coming in, they're having a decision, a watchful wait, and they suddenly get forgotten in the process. At each point, the patient is touching the services within the NHS. They're given a code, which is these numbers, 10, 20, 32, 45. So those numbers indicate that something has happened with that patient. So we have to monitor and make sure that the process of those is right. At the same point, you've got 3,000, 4,000 staff who are putting these numbers in, and they may not be as clued up on what they're supposed to do. They may not know whether this is an outcome. They may not know whether the treatment was actually an effective treatment. We have complexities within this, and it goes wrong. Typically at the moment, then what happens is that data gets cleansed through a validation team. That validation team will then look at all the data. But if you've got a validation team that's looking at every single transaction, you're essentially telling your whole staff, we don't trust you to do anything right, so I need to be smarter in my validation. Now, True, they are junior staff and therefore more affordable than your consultants, but why have them when I can work smarter and we can start looking at what should be validated right, and where people are making things wrong, understanding who made it wrong, re-educate. Start producing the tools that enable performance management. So we have an access policy as well, because there's rules to how you engage within the NHS as well. So essentially, with the model is 6 weeks, 6 weeks, 6 weeks. Okay, so there's your 18-week timeline. So you've got 3 weeks at the beginning to organize things, 4 weeks in the middle to kind of organize the diagnostics. So the gray patch is the minimum time that someone needs. So if I told you that you have a consultant, you're supposed to have 3 weeks notice before you come in. I can't give you notice in 1 week. You can only see a consultant. You might have a holiday. You might have to arrange things. So there's the model. The slowest time you can do it, yeah, we could stretch it out 5 weeks to arrange everything, and then you've got to have these gaps where you know you need to leave sufficient time. Or the fastest you can do it is actually 11 weeks. It doesn't leave you much room and much gap. So this is kind of the golden time of trying to get things right. And we often fail, but we are allowed 92%. The performance we're supposed to make is 92%. So as a patient, you have every right to say, I'm sorry, but I booked a cruise for the next 3 months. I'm not coming in. And you're part of that 8% that's allowed to be outside of that 92%. But 92% are supposed to be going through the 18-week target. We have to meet that. Our challenge is to meet that and make sure that we've got the best pathway for the patient and we're accurate. So what we do is we look at what's going wrong and how we correct that. So we're looking at the validation rules. We've got duplicate pathways. So that sometimes happens. You know, people put things on twice. You've spoken to one person, somebody else puts it on. So we're going to try and identify duplicate pathways. You've got DNAs for new appointments. So if someone DNAs, under what conditions do they get a new appointment and the clock keeps starting? But we still want people in. Just because someone DNAs doesn't mean to say you just go, oh, well, it doesn't matter, they're not coming in. They were given a referral for a reason. The last thing you want to do is leave that and then have them coming in as an emergency treatment later because the condition exacerbated and got worse. So you've got the incorrect RTT status might be put in. Patients not being tracked, clinical letters not typed and can't be validated, no electronic discharge notice can't be validated, should have been discharged. All of those reasons need to be looked at, and those are the top reasons that we want to do. So we built a tool within Alfresco to filter those and enable us to see those top reasons first. So then you've got the tracking rules, because essentially you get caught up in this, within this engine of running the hospital, you can sometimes get forgotten about. Especially if you've cancelled an appointment and you haven't had time to say, oh yeah, let's make a new appointment, so it's left open. So you've got this, so what we're trying to do is no appointments being booked, clinic letters not available, needs diagnostic awaiting. So along this pathway, there's lots of reasons why we are trying to identify what's going on with the patient. So within the elective, the process flow, so what we've essentially got is we want the clinical software to be the one version of the truth. And what we're doing is we're pulling that information into Alfresco, using some SQL queries over the top of that, giving that as a view to our staff. Our staff then look at it, check what's been invalidated, whether there's errors and better pathways. They'll update the status. That feeds back into the clinical system, and then every 2 hours it polls and redoes the data. So then next time it comes round, it's not coming back into the system because, of course, it's been cleaned and it's been validated as correct, or the appointment has moved and we've actually corrected some of these pathway changes. So this is the pathway tool that we've built. So essentially what we're looking at is the tasks that people have, whether it's, and we split it into the specialties because that's kind of the common sense way of dealing with this, because each specialty deals with patients in a different way. And this is how every hospital has the choice of how they manage their services. This is how we manage our services. And what we've done is we've thrown things through and have the work cues showing what we're doing with the breast surgery, cardiac, cardiology, audiology. So essentially what's coming in is you've got the filtering by validation. So you've got all these numbers coming through and you'll claim the case and bring it into your system, and so that you can then start working on this and make the changes on the clinical system to then throw that back. So you filter by validation rule. You can start looking at the filter. So you could have someone working on the clinical wrong sessions, the DNA for new appointments, someone working on duplicate pathways, duplicate referrals. All of these have been identified from looking at the data, pulling that data, doing the SQL queries on that, and making sure that we've got a view. So I'm not validating now everything. I'm not trying to do, because putting things into perspective, we have 330,000 outpatient appointments per year. I don't want to validate all of that. I just want to validate the ones that we identify as knowing that there's going to be problems. So you can then choose what's going wrong. You claim those orders. We then do the validation and check on the filter by tracking. So these are all the tracking rules that are coming through. Again, claiming those. And then triggering the use case, but we also need to capture the information to make people who are doing this wrong get it right. I need some tools to help doing the performance management and stop people putting the data in wrong in the first place. So we've got ways of putting in the tracking rules in, escalating them, actions taken, and getting the feedback so that I can performance manage the staff and get good data through. Because in order for me to become an information-led hospital, I need good quality data. I need people doing this right. And we also want better outcomes, because this is the way to get better outcomes. So this is the action taken and the summaries of the action taken. And that's my presentation. Thank you. Any questions?